Good afternoon. It is April 18, 2023, and I'm Dr. Duke Majan. We're at Duke Spine Institute getting ready to perform our second spine surgery for today. And our patient travels from Texas with her husband, where she has been treated by doctors in Texas, and she's had back pain, leg pain. They've done surgery. I'm going to show you an x-ray in just a moment. It's going to make your skin crawl. This x-ray is going to show some of the surgeries she's had on her back already, okay? And I'll need Jordan to get to his mouse and start to show us some of the things we've got here. All right, let's go to a side view x-ray. Can you see it, Henry?
Yes, we can.
All right, so first of all, can you see the white arrow moving?
Yes, we do.
Now, just to orient everybody, this is the lumbar spine. Let's show the L5 vertebral body because you really can't even see it very well anymore. That's L5. And where is the L5-S1 disc space? Right there. Good. And there's some little metal things. They look like staples. They're actually markers that are in the front and back of a cage that was placed through the front. Show us through the front. Yep. The surgeon came through her belly, took out the disc, and put a cage in there. Then he bolted a plate to the front of the spine, and the purpose is to hold the cage in place, prevent it from spitting out into the abdomen and pelvis, and then it's also to hold the bones together. Show us the screws in the S1. Yep, there you go. Now, after that surgery, she had another fusion because that one fusion wasn't enough. She was still in pain. So the surgeon brought her back, and they fused L4-5 for adjacent segment disease. And what you're seeing there, show us the inner body cage, but it's not really a cage, it's actually a bone graft. So it comes from a dead person, and they chop up that dead person's bone in his leg into little biscuits, and they push one of those bony biscuits into the L4-5, again, through the front. But to keep it in place and keep it from popping out, they put a single solitary screw drilled right into her L4 anteriorly with a little washer around the tip, which you pick up at Home Depot, and it keeps that bony cage from popping out. And by the way, folks, that wasn't enough. And just like spine surgery today in the year 2023, when you don't go to Duke Spine Institute, when you don't get the best treatment in the world, this is what happens. Multiple back surgeries. So they brought her back because she was still in pain, and they put in a spinal cord stimulator. There it is. That little device costs around $30,000. That's just to purchase it, and then to put it in is another $10,000 to $15,000. So you're looking at about a $50,000 price tag. Show us the wire running off the device and up her spine. Yep, there it is. And the little things holding the wire under her skin right there. Yep, little buttons there. All that is implanted in your body, called a spinal cord stimulator. I get a lot of questions about spinal cord stimulators. Dr. Duke, should I get a spinal cord stimulator? Hell no. Get the right surgery done the first time and you can avoid all this nonsense. We're going to fix this woman's disc with no metal, no fusion, no through the belly, no through the back, just tiny little 7mm incision. And had we gotten to her first, she wouldn't have any of that stuff in her back. She wouldn't be getting a 5th, 6th, 7th surgery that she's getting. All right, we're going to get started. We're going to start on the right side. Her problem is that above her fusion, she's got 2 discs that are now bulging out, pinching her nerves. Let's see, go north. All right, the first one we're going to access is the 3-4. Show us the 3-4. It's right above her prior fusion. That's right. Shot. So here we come. Probably want to start a little bit higher. Let's numb this up. I'm going to put some numbing medicine in her skin to make my anesthesiologist happy. Are you smiling, Dr. Berndes? Under your mask. So you can see the skin is starting to get the peau d'orange. It's French. It means the orange peel. That means that something is being infiltrated under the skin, peau d'orange. You like my French? That's for all my French-Canadian patients out there. All right, here we go. Shot. Remember, we're going to want to access 2 discs, the 3-4 and the 2-3. I may want to be a little bit higher, but let's just see. Shot. I could feel the arthritis that I'm approaching. I'm going to see, maybe start a little tiny bit higher. How's our blood pressure?
Good.
All right, shot. I can feel the facet joint. Show us the facet joint. It's full of arthritis. Uh-huh. Good. Yep. I have to get around it. That's my task. Shot. I'm aiming for her 3-4 disc. Shot. A lot of bone here. Some of that bone is from her fusion. So when doctors do fusions, they put bone graft on the side of the spine, and it makes it really hard to do more surgery. And that's what I'm bumping against, her bone graft. I'm slipping around it towards her disc. She awake? Yeah.
Hi.
Lay still.
My friend, can you open
Shot.
your eyes for me?
Uh-huh.
Can you open your eyes?
Shot.
Open your eyes. That's okay. Keep your head down. Open your eyes. Dr. Duke has some questions. Open your eyes.
Shot.
Good. Keep your eyes open
Perfect.
for me, okay?
That's what we want right there. Shot.
Okay.
All right. We're heading to the frame. Just wait. Just wait. Good. AP. All right. So I feel the herniation. Give me an AP. I want to make sure we're not too far lateral. Sometimes when you have a big facet joint or you have bone from a prior surgery, it will push your needle laterally. Hey, look at that. Stay there. Let's show the audience what's going on here. Can you guys see this? This is a great picture. So let's go to the needle. We'll start at the needle tip. I am sitting right outside the herniation. I can feel it with the tip of my needle. And it's right above her fusion L3-4. We're on the patient's right side. Show us that bone graft that I was talking about from her prior surgery. There it is, Jordan, great job. All of that, folks, is abnormal bone. The surgeon from the prior fusion stuck it on her back. By the way, I didn't mention this, but they went through her back and through her belly, both. She had it from both sides, okay? Now, it's not in a good way, it's in a bad way. And she has scars on both sides of her body from all the surgery they did on her spine. And here she is still in pain. No better than she was before, she told me. Now stay there, Jordan. I want you to point to the wires in her spine. This looks like this is not an electrical job for an electrician to wire something. This is a human being. And these wires are sitting in their spine. Folks, this is what your doctors want you to have. They want you to have these wires put in. Why? They make $10,000 profit every one of these they put in patients. I've seen doctors now go, show us the leads up in the spinal cord. I know doctors are putting these things in left and right, recommending spinal cord stimulators left and right. Why? I can tell you why. Not because they're electricians, it's because they make lots of money doing it. Look at those contact leads, folks. Each one of those black dots is a contact point made out of metal, hooked to a wire connected to that generator, running up the entire spine. They don't show you this because they don't want you to see how invasive it is. But that thing is sitting on top of her spinal cord. Now, it is helping her. She said it gives her some relief. But still, she's in suffering and pain every day. She can't do anything. She can't walk. She can't work. She can't do her house chores. She can't take care of herself. So she flew all the way from, or drove all the way from Texas with her husband to come here to get fixed, to Duke Spine Institute. And again, had we gotten to her first, none of this would have been necessary. All right, is she reliable? If she's not, I'll just work on 2-3.
Hi. Can you open your eyes? Yes, hi. Can you keep your head still, okay? Hi. She's opening her eyes, keeping her head still.
All right, let's go ahead and put the next one in higher up. I need you to show me 2-3. 2-3 is going to be a little harder to get to.
She's a little sleepy, but okay.
Yeah, we're going to give her a little more time to wake up.
Okay, perfect. Sounds perfect.
We've had to keep her quite sedated because she's in so much pain from her.
Being on her tummy, yeah.
Any questions from our audience?
Yes, we have a couple questions.
Before we take the questions, let's show the audience the video showing how is it that a disc can be so painful.
Traumatic injury to the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissues develop within the annular tear, causing back pain. The inflamed annular tear generates pain signals. Additional injuries can cause symptoms to worsen. Inflammation from the annular tear can spread to nearby nerve roots, causing leg pain. Signals travel up nerves to the brain, causing localized back pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of pain. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.dukespine.com.
Welcome back. We're working on lining up the spine with the needle. And before I start advancing the needle into the spine, I need to make sure, I think that's about as good as we're going to get it, Jordan. Show us what we're looking at. Show the audience what we're working on. We're working on the next disc space up. No, that's too far. It's that one right there. Yeah, that's the one. So we're trying to get and show the back of the vertebral body, left and right. You see it's offset. Just show the back bottom corner. Down right there. And that's one side, and then show the other side there. We're trying to get those as lined up as possible. At the same time, lining up the pedicle below. Show the pedicle below. Yep, that bone just down a little bit. That's the pedicle, and come down. Keep going. There's the bottom of the pedicle. So we want to line that pedicle up, left and right sides, with the lateral view lined up with the pedicle above. But we're not going to because the patient has scoliosis. So we're going to do the very best we can. But because of her scoliosis or twisting, we're going to have to make do with what we've got. Okay, so I'm trying to access transforaminal shot. The L2-3 disc, and I'm lining up perfectly for it. You having any pain? Where is her pain? Don't move.
Keep your head still.
Shot.
Where's your pain? In your leg or your back? Where?
In her back?
Back. Back, yes.
Give me an AP. That's perfect. If we're in the right spot on the AP, then we're golden. So I've already got one needle placed at 3-4. You can see that below. And now I'm trying to get the next needle placed at 2-3. It's hard. Nope, we're nowhere near it. You can see why. Because her spine is so twisted. I'm going to have to do a second incision for her. I'm going to have to start higher up. Give me some num-num. Relax, you're doing great.
Doing great. Keep your head still.
Just don't move.
Keep your head nice and still.
So because her spine is twisting away from this right side, going off to the left, I have to go a little higher and a little more medial on my entry point. Shot. All right. Is Arias there?
Yes, he is.
Arias, when you get up to L2-3, higher up in the spine at the fourth disc up, you got to worry about kidneys. And if you start too lateral, you can hit the kidney. So you want to be just medial enough that you don't do that. A lot of doctors don't know that. So you see how I came more medial with my entry point? I didn't start super lateral like I do with other levels further down. So the further up you go in the spine, you have to start more medial. And the further down you go, you can go more lateral. All right, teaching my protege. All right, we'll take the questions from the audience. Shot. So I'm hitting bone, and we need to do something different here to get to L2-3. Shot. Meanwhile, while we're working on this, let me take some questions. Shot.
Next question. This question comes from Trust on YouTube. And they ask, can all of that metal be removed?
So Trust is asking, can all that metal be removed? The answer is yes. We can take all that metal out. There's no reason to. Because the damage that was done putting it in. All the scar tissue, all the damage to the blood vessels, the intestines, the ureters, the nerves, all that problem, it was all done when they were putting it in. All right, so you can see we're doing a little better, but we're still too low. So I'm going to have to go even higher. Num num. I don't have to go much higher, but I do need to start a little bit higher. It's because her spine is so twisted. We're not fixing the twist of her spine. We're just going to fix the pinched nerves. You're doing great. Hang in there, Sean. Okay. Huh? Sean? Yeah, she's doing really good. Sean, I feel like I'm still hitting that transverse process. Go AP. Any way you can get that disc space open up a little more? I can't do anything about that. Oh, we're close. Look how close we are. All right, we're close. Looks like we're on the wire, right? Doesn't it, with the tip? But we're not. The wire's further back. Shot? Yeah, you can see how far back the wire is. There we go. You're doing great, Sean. All right, this may be higher than I want to be. But let's get an AP. Where do you feel it? So I need her help.
Pain? Your right side, so in your back or your legs? Your back pain, right side.
Mm-hmm. If you look at that picture right there, we are not too high with the tip of the needle. Show us the disc space on that picture. There's the disc space. So the needle is in a really good spot, really. But on the lateral view, because it's so scoliotic and twisted, the needle is not in a great spot. Show us the arthritis in the facet joint there on the left. You guys see the arthritis? Nope. The other side? Yep, that facet joint. Just go down, down, down. There. See it up a little bit? See that? See the crack right there? Show them the crack. Yeah, that crack is the facet joint. And then the dark bone on the sides of it is hypertrophied bone, sclerotic bone. So the bone is thicker there because it's reacting. Okay, making some progress. Sean, where do you feel that?
Back.
Mm-hmm. Yeah. Let's go, AP. You doing okay? Now you can clearly see from the entry points of these two needles that I cannot get the surgery done with one incision. I'm going to have to do two. You can also see from that picture that we are not too high in the foramen. We're actually right above the pedicle of L3. Show us the pedicle of L3 on that picture, Henry. See the pedicle of L3 right there? That circle? You see the needle? We're just above the pedicle. That's where you want to be. Mm-hmm. Yep. So, you okay? Where do you feel it?
Where are you feeling that? Tell us.
Where do you feel it?
Where are you feeling it?
Shot?
In your back or your leg? Back.
In her back. Perfect. Yeah. Not easy. You're doing great. And I apologize. We're going to have you asleep very soon. Shot? All right. Let's get an AP again. Right above, skimming right above her bone there. Mm-hmm. Not bad. Mm-hmm. The problem is I can't really see it well on the lateral because of her scoliosis. So I'm trying to... Shot? Any way you can give me a better lateral view? You're going to have to really bring this arm further north. wag my side north. The arm board, come on. We've talked about the arm boards, guys. The arm boards are always supposed to be as far north as you can get them. Shot. Now what if we were, oh, that's much better. Much better. Look at that. That's beautiful. So I need to be a little higher. That explains it all right there. That's why the positioning of the fluoro is so important to getting the surgery just right. I'm scraping right along her end plate. So tight. So tight. There's just a millimeter window here. And I'm trying to, well, worst case scenario, I'm at the entrance to the disc, so I can certainly get the entrance to the disc. Now, are you comfortable?
Yes.
We're going to get started in just a minute, okay? I just needed your help for that, and I'm sorry you had to be awake, but it's essential that you're awake for that part. All right. Now, do you have much back pain?
Not so bad.
Yeah, your leg pain is so bad you don't even think about the back pain, do you?
No.
All right.
Oh,
How bad is that on a scale of 1 to 10?
yeah.
10. We just tested her disc with a discogram at L2-L4. Is that where you get your back pain typically?
Yes.
10 over 10. And that's concordant, so it's a C. Take this. Now, I don't know if I'm fully in the disc at the next one. We're going to find out just now because the dye will show us. Shot? No. We're more in the epidural. We're just at the back of the disc. So that one didn't really give me a good discogram. Let me have the stylet. I'm going to try to relocate it just real quick. One more time. Well, I can. Huh? Not yet. I really, in a minute I do. Yeah. Shot? I just want to get into this space, if I can. Shot? The approach isn't bad. I wonder, she's just so twisted, you know, with her spine. I'm thinking I'm just going to leave it. Give me an AP, because I'm right there at the back of the disc, and she's so twisted, her bones are out of alignment, that getting in perfectly right now is going to be hard with her awake. But I am happy with the location. It's at the bottom of the disc where it needs to be. I'm happy. Let's just leave that. All right, let's get started. So we're going to put her to sleep. She's going to count from 1 to 100, and when she goes to sleep, we're going to start with L3-4, and then I'm going to do the L2-3 later. Any questions?
Yes, we have a question from Oz on YouTube,
Yes, Oz.
and they ask, why do some doctors use T1 MRI method to rule out a disc as opposed to T2?
Why do some doctors use T1 MRI scan, and it's called, the sequence is T1. Shot? You're okay. Lay still. You're doing great. The reason is they don't know what they're doing. I do not use a T1. I only use T2. I was taught to use T1 25 years ago, but it's the wrong sequence. The only reason to use a T1 is if you're looking for tumors or scar tissue, or where you do dye, and you do a T1 with dye contrast to look for a tumor, but that's so rare to find one. Anyway, I don't use T1, I use T2. So I would just call it lack of experience. That's the only thing I can think of. A lack of experience, a lack of knowledge, a lack of understanding. There's honestly spine surgeons doing degenerative conditions of the spine should be looking at T2 weighted images for degenerative disc disease, not T1 images. Now radiologists do need the T1
You're doing fine.
because the T1 gives some information about fat and other things that we're really not that interested in. Great question.
We have a couple more questions.
I'll be happy to take them.
This next one comes from Darren Sanders on Facebook.
Hello, Darren. Thanks for asking.
And they asked, looks like she has some scoliosis. Is that causing pain?
Yeah, she does have scoliosis, for sure. It is not causing her pain. The reason I know that is I've done this surgery on hundreds and hundreds of patients with scoliosis, and I've cured their pain. Meanwhile, I never touched their scoliosis. I left it alone. So they came into surgery with scoliosis. They came out of the Duke laser disc repair with scoliosis, and their pain is gone. The reason it's gone, because we are going after the source of pain, which is not the scoliosis. A lot of people don't understand that. They think scoliosis, spondylolisthesis, stenosis cause pain. But scoliosis, spondylolisthesis, and stenosis do not cause back pain. It's a misunderstanding. Stenosis will cause pinched nerves or spinal cord, which can cause leg weakness, numbness, and tingling, but not really pain. The pain comes from inflammation. That's why epidurals help with leg pain and arm pain, because you're dealing with the inflammation rather than a structural problem. Epidurals don't fix structural problems, they fix inflammatory problems. An epidural steroid injection is an injection of a steroid. A steroid is an anti-inflammatory, that's all it is. It eliminates inflammation. Nothing more, nothing less. By reducing inflammation, it reduces swelling and pain. All neck pain and back pain comes from inflammation. So fixing a herniated disc and fixing stenosis does not fix back or neck pain. Fixing scoliosis does not fix back or neck pain. And fixing kyphosis does not fix back or neck pain. Fixing listhesis does not fix back or neck pain. The only thing that fixes back and neck pain is getting to the source of the pain, which Duke Spine Institute is the first in the world to identify. That source of pain definitively is the annular tear that's inflamed. Now, there are other doctors that came before me that thought that the disc was the cause of the pain, specifically inflammation in the disc, but they didn't have the ability to prove it. One of them was a neuropathologist from Sweden, and his work was done 80 years ago, and he did he cut up cadavers, dead people who had back pain in his town, and he saw that the disc in those patients with back pain, the disc had this weird shape and structure to it that was not normal. It actually had scar tissue in it, inflammatory tissue in it. And he took pathology slides and stained them of the disc, and he showed that that tissue was inflammatory tissue. And I studied his work many years ago and realized that he was right, that those painful discs have inflammatory tissue in them. Okay? And of course, Cloward, who was a famous neurosurgeon that we all know, he actually suspected the disc was the source of back pain as well. And so he did some experiments where he went inside people that had back pain, and he poked on their discs with a probe, a metal probe, and guess what? It elicited back pain. So these doctors did some experiments that confirmed, well, in Cloward's case, confirmed that the back pain was coming from the disc, but nobody understood why the disc was painful. And that's where Duke Spine came in and discovered it's the annular tear that is in the back of the disc, the posterior annular tear, that's causing all the pain. Okay? And we've been treating it now for 16 years here at Duke Spine Institute with this surgery you're watching right now. You're not going to hear about this surgery from other surgeons because they don't know how to do it. They don't know about it. Okay? They're too busy doing fusions for scoliosis and kyphosis and listhesis. They're not interested in less invasive treatments because they don't pay them as much. Unfortunately, surgeons, most of them will do what's best for them and not what's best for the patient. All right, more questions.
Yes, next question comes from Oz once more on YouTube.
Hello, Oz.
They ask, why does her spine look crooked?
The crookedness of her spine is called scoliosis. And it wasn't that way when she was born. She developed that over time, mostly because of arthritis and injuries to her spine. Those injuries were to the discs and to the facet joints. And when you injure a disc by tearing the disc, the jelly or stuffing inside the nucleus can come out. And when it comes out, it then, this damn herniation is not coming out. It then can flatten out. And as the disc flattens out, the spine will twist because the disc was holding the spine up. So as the disc starts to flatten out, the spine collapses. As it collapses, it twists. Okay, if you have go in your car and you run over a bunch of nails, your tires are going to start to flatten out, but they don't flatten out equally. They flatten out some more than others, which means your car is going to rotate as it sinks. The front may sink more than the rear, or vice versa. And so that's what happens to your spine, but at multiple discs, it's amplified throughout the spine. So the spine is twisted. It's called scoliosis.
We have another question.
Sure.
This comes from Trust on YouTube once more, and they asked, grade 1 retrolesthesis L2 to L3. What is this, and is this the surgery to repair it?
So grade 1 retrolesthesis is a slippage backwards of bones. And again, you don't need anything done but the surgery you're watching right now. This surgery is the best surgery for a grade 1 retrolesthesis. Why? Because the retrolesthesis is not the problem. It's still the herniation and the annular tear. That's where the pain comes from. So you don't have to do anything other than the Duke laser disc repair. What you're watching now. By the way, the blue thing is the laser fiber. Coming off the bottom is glass. Glass is what transmits the laser energy from the machine to the disc where I'm using it, directing it where I want it to go. And I'm directing it to get rid of this really bad tissue here that's damaged, inflamed, and causing all the pain. It's called the herniation. And when the herniation's been there for a while, it becomes degenerated. Degenerated means damaged, destroyed, dehydrated. There are biochemical changes that occur at a biochemical molecular level that are permanent changes. They're irreversible, meaning you can't go back and undo them. So the disc has been damaged permanently through the injury, originally trauma, and then after trauma, the herniation has come. The herniation has then caused the chemical trauma to occur, a second wave of trauma from inflammation. It's the inflammatory injury that really is what causes all the pain that people experience. And that's what we're treating with this surgery.
We have another question. This comes from Casa once more on YouTube. And they ask, C6 through C7 fusion and an L5 to S1 discectomy post-op times 1.5 per year. Pain returned. I live in NY and can't return to Florida to your practice yet. I will, but in the meantime, is there an injection that you can recommend?
Yeah, so for me to recommend an injection would be recommending a treatment. I don't treat patients unless I'm treating them and evaluating them first. there is no injection I would recommend. And the reason is that now you're diagnosing and treating yourself, which is a big mistake, because pain is not the only problem. There are other things that can happen, like nerve damage. And if you have nerve damage and I'm recommending a shot, that would be malpractice of me to recommend a shot when you need surgery for nerve damage. So I don't do treatment like that just whimsically over the internet. You need to be evaluated. And Henry will put a link. We're happy to do it. It's called dukespine.com/VC for virtual consult. Okay, dukespine.com/VC for virtual consult. Since you can't make it to Florida, then we can certainly evaluate you and treat you through a virtual consultation. And that's done over the internet through Zoom. You have to schedule it, and we're putting the link up right now for you to do that. You're going to need to load your MRIs. You're going to need to give us some history. And then once I've done my exam on you, then I can make a recommendation. But I can tell you right now, if you've got nerve damage, shots are not the way to go. I'm not going to recommend a shot. You need surgery. The only problem is figuring out if you have nerve damage requires a physical exam and a nerve test. I'm sorry, folks, but fixing back and neck pain is not always convenient for people. You actually have to travel. It's kind of like if you want to go to Disney and you want to see Mickey Mouse and ride the rides, taste the food, and enjoy the scenery and the ambiance, you have to come to Orlando or California usually. There are some other countries that have Disney now, but you got to travel. You got to be willing to travel for the experience. Duke Spine and fixing people's backs and necks, it's not something you can do over the internet. It's something that has to be done with surgery. And surgery cannot yet be done over the internet. Maybe someday. Maybe someday when Arias is practicing, he can have a robot set up in every city. You walk in, take your clothes off, lay on the table, and a surgeon at Duke Spine will robotically fix you. It's not a bad idea, actually. That's really the main purpose of robots. That's why robots were originally brought into medicine, was for military applications, where patients that were injured in war could be overseas, like in Iraq, and they could still get surgery done with a robot. That was the original purpose of robots, military applications, and they were great because it works. But currently we don't have that capability, so I would suggest whatever you do, get a consultation first, and then from there figure out what's wrong and what needs to be done to fix you. And that goes for everybody, by the way. So I don't recommend treatment just listening to you guys talk and coming up with a treatment plan. That's not good medicine. That's how you create problems for patients. If you want to treat people properly, you have to do a history, a physical, and you have to review all the diagnostic imaging that's necessary. All right, we're almost done. This disc is very badly damaged. Look at all the scar tissue, massive amounts of scar tissue. It's actually worse here that I'm seeing now in surgery than I did on the MRI. So the MRI does not do this injury justice. A lot of people think MRIs show you everything. They don't. MRIs have massive limitations. It's really knowing what's wrong with a patient causing back pain. It's really up to the doctor to make that diagnosis. And the MRI is only part of figuring it out. It's not everything. A lot of people think their MRI shows what causes their pain. It doesn't. What's causing your pain cannot be seen on the MRI. The MRI just gives you clues. But it takes more than an MRI to diagnose the source of back and neck pain. If MRIs were so accurate, there would be nobody with back and neck pain. But problem is everybody has back and neck pain because the MRI doesn't tell you where the problem is. It's the whole point. We've had MRIs now for 30 years, 40 years. And we have still people suffering with chronic back and neck pain because the MRI doesn't tell us where your pain's coming from. A good doctor will tell you. All right.
We have a couple more questions.
Uh-huh.
These next ones come from Darren Sanders, once more, on Facebook.
All right, great.
And they asked, how did you discover this technique? And if someone suffers from chronic inflammatory disease, does that change your approach to fixing their pain?
Hey, Darren. First of all, how did I discover this treatment? Great question. It was actually kind of accidental, to be honest. I was trying to treat pinched nerves that were causing leg pain and pinched nerves that were causing arm weakness, numbness, tingling. We call it radiculopathy, okay? So I was trying to treat what's called lumbar radiculopathy, which is pinched nerves in the lower back, and cervical radiculopathy, which is pinched nerves in the neck part of the spine, by the way. So still the spine, but just in the neck versus the lower back. So I was treating these pinched nerves endoscopically with the laser. Well, I was treating them endoscopically, and then I brought the laser in, and because the other tools I was using really weren't working, they weren't grabbing the pieces of herniation effectively. So I brought the laser in to help remove the herniation that was pinching the nerve. And as I was cleaning up the tear where the herniation came out of, getting all the pieces out, I realized afterwards when the patient woke up and their back pain was gone, that their back pain was gone. Same thing with the neck. And I realized at that moment that I was onto something new that was curing pain in the back and neck, at the same time fixing the pinched nerve. So I realized after treating a few patients that we had something new here, and I didn't understand it at first, what I was doing, how it was helping them, but we figured it out pretty quick. All right, we're done here. That's the 3-4. You can see the nerve right there, the nerve root, the bottom of the nerve root. So we're done. Here, we got to do the other disc still. Anyway, it was purely by accident that I came across the technique. And I knew I was treating the pinched nerves, so I was treating the leg weakness, numbness, tingling, but I didn't realize the back pain would get better, or neck pain. And then, like I said, I talked to my patients, and they were so happy their pain was gone. It's a little too light. And that's when I realized, okay, I'm doing something that my colleagues, my peers are not doing. And it's working to get rid of the back and neck pain, which they're not able to get rid of with their surgery. What am I doing different? And that's when I realized the annular debridement was the reason. It was the annular debridement that I was doing differently. And that was the key. One disc down, one more to go. So right now we're going to bring in the fluoro again so I can navigate down to the disc. We're going to get into this disc and we're going to fix it. I'm going to give my anesthesiologist a minute to get the patient a little deeper. Are we using the CPAP?
No, not today.
Any reason why?
Facial anatomy.
Interesting. Do we need to take measures to accommodate for that in the future? All right, any questions from the audience?
Yes, we have a question from Trust on YouTube. And they ask, what is modic fibrotic end plate and edema end plate change?
Modic changes are irregularities of the bony end plate. Fibrosis is scar tissue, and edema is swelling. I like how Trust is trying to get an MRI review out of a surgery questionnaire. So Trust, you're going to need to do a consultation to get more specific answers for your problem. You can't just make generalizations based on my answers to other people's questions or yours. You need to have a personalized consultation, and that's the dukespine.com/VC. All right, shot. We're going to move on to the next disc. Is there any way you can give me a little bit better? You're almost perfect, but I think my side needs to go further north. So it's a little more wag. Otherwise, your orbit is really good. That's not bad. Not bad. Is that as good as you can do it? Yeah, because you're hitting the arm board, right? Yeah, no problem. I think we're good. I think we can work with this. Tell me when you guys are ready, Berndes. Knife. Give me some more num-num. I'm going to give some more numbing medicine before I incise her. But basically, I was not able to do both one incision and fix both discs. The reason is because if you look here, you see one incision is here, Henry, and the other one is far away. It's at least 2 inches, 3 inches away. So when you're a surgeon doing the surgery, you're not always able to get everything done with one incision. It depends on the curvature of the spine, and her spine is pretty curved. Can I proceed or not yet? Yes? All right. Here we go. By the way, we couldn't do it on this side, but if we were to repeat the surgery on the left side, I think we'd be able to get both discs with one incision. And that's just because we would be operating on the lesser, what's called the lesser curve, the scoliotic curve, the lesser curve, which means it's the concave side, right? So the disc would point to the same point on the surface if you projected them. Shot? All right, now this is a trick I'm doing. I'm holding the guide wire, pushing it down against the disc so that it doesn't move. I don't want it moving. Meanwhile, I'm bringing my dilator down, shot. Okay, now I'm in the foramen, and I'm approaching her herniation right now. I'm touching the herniation. I can feel it. Okay, I feel the herniation. And I've got to get into that disc space. Now, I already know that my needle was on the low side of the disc space. I feel the herniation. My needle was at the bottom of the disc space, okay? So I need to be a little higher than where I was before. So as I come down with my tip, I'm going to bring it down, and then I'm going to aim it up a little bit so that I can slip into that disc nicely. I'm fine. Takes a little maneuvering, a little MacGyvering. Shot? You all know MacGyver? Everybody knows MacGyver? Or am I the only one? Take this. I've sort of trapped my guide wire. There we go. Shot. All right, so we're right there. We're inside the disc. And now I can do a discogram, which I plan to, because I really would like to stain the bad nuclear material blue. I may have some junk in there. But let's see. Well, let's see. Shot. I feel it go. There it is. So the dye is going in. You can see it leaking out through a tear in the back of the disc. So I'm happy with that. It's better that we did it rather than not do it. That way we have a little bit of the blue dye to guide us. Here we go. We're doing the whole surgery, by the way, through this tiny little straw. You see this?
Yes, we do.
You pick these up at McDonald's. They're right next to the shake straws. I wish. The whole surgery would be a lot cheaper if that were the case. Any other questions? Shot?
Yes.
Anybody?
We have a question from Oz once more on YouTube.
All right, Oz.
And they ask, is there a scenario where you will have no choice but to do a fusion as opposed to the laser based on the structural and physiological changes of the disc and spine?
Yeah, so is there a time where we would need to do a fusion? The answer is no. 99% of patients that are recommended for fusion don't need a fusion. They could just have the Duke laser disc repair. So there's your answer, 99%. So let's just say 1 in 100. And that 1 in 100 spine would be so twisted, so collapsed, that it would be impossible to do the surgery. Now, I've not met anybody like that, but I'm sure they exist. So we'll just say 1 in 100. That way we cover all of our bases. You got it? That would be like saying, is there ever a situation where someone's thirsty and they need water to drink, but they couldn't have water? Well, I don't know of anybody that couldn't have water, but I guess there may be somebody out there. So as kind of crazy as it seems, I'll just admit that maybe there's one person in 100 that couldn't have water. Okay? But you get my point. I know got it? I know it's hard for you all to understand that because everyone's brainwashed to believe fusion is necessary all the time, but it's not.
We have a couple more questions.
I'll take your questions.
These next few come from Trust on YouTube. And they asked, first question is, what is the wait list time to get this surgery?
What is the wait list time? That's a great question. I don't keep track of the wait list, but we don't believe in making people suffer philosophically. So our policy at Duke Spine is everybody has to be, if they want to come here, they have to be seen within 2 weeks. So the point is that if the patient doesn't want to be seen within 2 weeks, they don't have to. But if a patient calls and says, I'm in pain, I want to be seen as soon as possible, and if I find that my staff scheduled the patient longer than 2 weeks out, they're going to have to answer to me. And I am not going to be a nice person about it. In other words, we guarantee you're going to be seen within 2 weeks. And if you're not offered an appointment within 2 weeks of calling, then I personally will get involved and I will personally talk to the people who told the patient they're not able to get in 2 weeks. And I'm going to Gestapo style grill them, and they're not going to be very comfortable when I'm doing that. So, my point is simple. If you're in pain, we want you here, we want you fixed, just as bad as you want to be fixed. And we're doing everything we can to accommodate you. We will see you, we will treat you immediately. It's just all about how soon you can get yourself here. We don't make people wait 6 months to come see us. As long as I'm alive running this business, the people will always be the priority. My patients will always be the priority. Let's put it that way. So, the patients can always come. We never turn you away. You're always welcome, as long as you're having some need that we can help you with. I think that says it best. Did I leave anything out, Henry? We need 5 minutes, guys. 5 minutes, we'll be done. Thank you.
I don't believe you left anything out. No.
I'm sorry?
I don't believe you left anything out. No.
Our whole point of being here is to help people get out of pain. I've heard of other doctors making people wait 6 weeks, months to get in and be seen. It's just, to me, it's disgusting and shocking and shameful for the doctor to do that to a patient who's suffering. We're not a pill clinic. We're not going to bring you here and give you pills. Pills don't fix anything. They just make people addicted and have a high potential for abuse. So we're not a pill company. We don't come here expecting to get narcotics. And by the way, none of these patients that get Duke laser disc repair, they don't need narcotics after the surgery, for the surgery. The surgery is so minimally invasive that there's no narcotics given to our patients. Okay? Now, if you've been on narcotics for years, you need to talk to your pain doctor about getting off of the narcotics after your surgery is done. And we can help you with that. We can help you get off narcotics. The purpose of our company is to get you off narcotics, not to get you on narcotics. So we're not going to get you on narcotics, but we will get you off narcotics. For those of you who don't know what I'm talking about, narcotics are a type of painkiller. There are many different kinds of painkillers out there. Anti-inflammatories like Motrin, ibuprofen, Advil, naproxen. Those are a type of painkiller. And then you've got narcotic painkillers, narcotic opioids like morphine, fentanyl, Demerol, oxycodone, OxyContin, MS-Contin. I mean, there's a whole list of them. And then you've got muscle relaxers, which are not narcotics, but some of them are very addicting, like Soma and Valium, which can be very addicting. And then you've got your Tylenol, which is also a painkiller that is very mild. It's the mildest of all. That's what we use for our surgery patients. All the Duke laser disc repair surgery patients, they all get Tylenol for their pain after surgery. Nobody needs narcotics. So we don't give narcotics out for the surgery patient. If you have a fusion, you're going to need narcotics. If you have a microdiscectomy, you're going to need narcotics. If you have a laminectomy, you'll need narcotics. If you have an artificial disc, you'll need narcotics. This is the only surgery in the world where you don't have to take narcotics after the surgery. All right, just about done. That's the back of the disc right there. Actually, surgery went better than I thought it would. If you noticed what I did a trick to get this disc access through the back. I waited for the patient to go to sleep, really deep asleep, and then I was able to get into the disc because at that point she's relaxed. Her muscles are no longer tightening on me, so they're relaxing. And when the muscles in your back don't spasm, you can actually, the disc itself will unload and open up. I don't want to use any analogies, but I saw a post on Facebook the other day. Well, I won't say it. I better wait till we're off.
You have a couple more questions?
I'll take some of the questions, or I can answer them afterwards if you prefer. When I come there, there's just a big old herniation right here. Can you guys see that? I'm trying to cut it in half with the laser so I can get it out. But I'll be happy to take another question or two. It wouldn't be bad to save a few for when I get there.
Of course. No, these next two questions come from Trust on YouTube, once more.
Uh-huh.
And these questions are, first one, what is severe right lateral recess stenosis? And second question, is a disc extrusion a herniated disc?
Yeah. So first question, what is severe right lateral recess stenosis? It's severe or bad. Stenosis is narrowing. It's bad narrowing of the lateral recess. The lateral recess, most doctors don't even know what that is. It's the space in your spine where your nerves run, just medial to your pedicle. So if you know where the pedicles are, and you go just medial to the pedicle, and it's basically the space under the facet joint. And I'm very used to treating that area. It's the number one place where people get significant stenosis. So whoever read your MRI, that radiologist, they did a good job. by mentioning that because that's an important area to look at. And then the second question was, is a disc extrusion the same as a disc herniation? The answer is yes. Disc herniations, for some reason, have like 10 different names. Everything with disc. Disc protrusion, disc extrusion, disc rupture, disc bulge, disc prolapse, slip disc, bulging disc. I mean, all those things are the same. It's a herniated disc, okay? And that's all that matters. You got a herniated disc or an injured disc, and that's where the problem's coming from, okay? It's just that so many people have different names for the same thing. How's my irrigation? Good? Yeah? All right, well, there's the nerve right there, and I'm just below it, and I don't want to injure it in any way, but I've just gotten rid of all the pieces of junk that were pushing on it. Can you guys see the nerve right there? That's the nerve. And it's buried in a little bit of ligament, so this is where it was getting pinched, and I'm just protecting it and cleaning it up. But this poor woman has been suffering with right-sided leg pain for years, 14 years she told me, and she's had all these surgeries done in Texas. None of them have fixed her problem. She found Duke Spine Institute. That's just below the nerve. You guys see that? That's the ligament below the nerve being right here. It's all, look at all the scar tissue on the nerve, all those strands, scar tissue from inflammation, okay? So I just got to get rid of this last little bit right here and we're done. About 1 minute left. A lot of it's calcified because it's been here for so long. See that? All that calcium buildup. Anyway, we just treated a patient from Texas, 2 patients, and she was on Facebook channel this morning. Look for her. Her name is Liz Lindsay. She's actually a nurse. She doesn't really tell everybody that, but she came to Duke Spine Institute with her husband last week, and let's just say they left very happy. All right, we're done. All the pain gone, both of them. All right, at this point, save your questions, type them up. I'll come answer them face to face. I just need irrigation. Look at this piece of herniation right there. Yeah. Type up your questions and I'll come answer them for you. But we're done for today. This was our last surgery. We'll be back Thursday with 3 or 4 more, right? I don't even know what we're doing Thursday, but it's probably Duke laser disc repairs, endoscopic surgery all day. When is that fusion? Do we ever find out?
I don't see it on the schedule yet.
All right, I'm going to show you in just a moment the incisions we made to fix her back. And again, the scoliosis, somebody asked me earlier, why is her spine so twisted? It's basically damage to the discs and facet joints causing a collapse of the spine under the effects of gravity over time, cause the spine to collapse but twist. Think about a house on its foundation settling. You build a new house, you compact the ground, you lay a foundation, but over time, so the house a lot of times, if you have a sinkhole or something underneath, the house will start to sink, but it doesn't sink perfectly down straight. It starts to sink more on one side or one corner or another, and that can cause the whole foundation to twist. All right, there's your 2 incisions. You see them?
Yes, we do.
This time Dracula was hungry and got her flank. All right, type up your questions. I'm happy to answer them for you. I think she's going to do fantastic. Our first patient already went home, and he had the 2-level cervical. Hopefully we'll do a nice testimonial on both of these patients tomorrow. And I'm Dr. Ari Dugmajan here at the Duke Spine Institute. I'm smiling because I'm sitting with my first surgical patient of 2023. I don't know if you realize that, but you were the first one of this year,
Okay.
of the new year. Now, you had the Duke laser disc repair done on your lower back because you had 3 bad discs. And we did that yesterday.
Yesterday, yes.
And here you are, one day later. How do you feel?
And I feel good. I feel good, and the pain that I've been suffering for months is gone. I mean, I was a little bit sore, but that's from the surgery itself.
Yeah.
But otherwise, I feel good. Feel good.
Now, you've had back pain too, on and off for 30 years. We were talking about that. Tell us about those episodes of back pain. What do they do to you?
The first one that I recall was pulling out a sofa bed thing. And I got so far with it, you know, we had company and I was opening up the bed, and all of a sudden I just could not move. I couldn't move. My husband had to practically carry me. So I was out of work for a week or so, and then at the chiropractor, and then gradually it got better, and I thought, well, that's fine. And I moved on. And then, you know, had a couple other times like that. One time I was drying my hair, getting ready for work with the blow dryer going like this with my hair, and all of a sudden, it's like I couldn't move. I couldn't move my arm down. I couldn't, I mean, it was that quick.
Yeah.
And just, I was out again for another week, laying in the bed and doing all that stuff. And then I thought I was fine, but I always, not always, but for many years now, probably at least those 30, I had lower back pain, where in the morning I couldn't bend over to brush my teeth. You know, that would really hurt.
Yes.
So I had that.
Do you have that pain now?
No, I don't think so.
It's gone.
The pain this morning, I was the first time in a long time I've gotten up first thing in the morning and was able to walk and not have that awful pain, because first thing in the mornings was the toughest.
I'm so happy for you. So how is this surgery going to help you in your life?
Well, hopefully I can, once I can at least walk again. I was not able to barely walk with a walker. I was very active in my church and my community.
So you want to get active again?
And being in such pain now since July, and this is the new year, I'm anxious to get back to, you know, my life.
Yes, of course. Well, you had 3 herniated discs in your lower back, and you can see in the footage where we went into each of those 3 discs, and I used a laser to clean the tear, where you had a tear in the back of each of those discs called an annular tear, and the jelly from the center was stuck in the tear, holding it open, allowing more herniations to come out. So I got rid of the jelly that was in there using the laser, cleaned out the tear, and now your body will be able to heal that for the first time in 30 years. So I don't expect you to ever have that pain ever again.
Thank you.
You're welcome.
I am so thankful.
Well, you had faith,
I am.
and you found us.
Yes, I
and
did.
You did what's right for your body, and I'm excited for you. So
I believe I did. I just kind of was led to you, and it just all went bing, bang, boom, and I didn't ask a whole lot of other people what they thought. I just did what I thought was I needed to do
good.
for me.
Is there anything you want to say to your fans out there?
I would recommend that if you do something to your back, that you take care of it early on. You take care of it right away. The longer you wait, the harder it is and the longer it takes.
It takes a toll on your life.
Oh, definitely. It has taken a toll on mine since this summer, for sure, where I have not been able to, sometimes not function at all, barely be able to sit in a chair and be comfortable without squirming because I couldn't find that exact place where I didn't have pain. You know?
I don't see you squirming anymore.
No, I'm not squirming. I know. That's great. Sit here without pain.
Congratulations.
Thanks to you.
All right, have a blessed day.
Thank you. You do as well.
Well, I hope you enjoyed that testimonial from one of our patients here at Duke Spine. And she had similar problems with her back, obviously, with the herniated disc, pinched nerves. And really, when you talk about a herniated disc, what we're talking about is the joint that is located in the spine. And the spine is really made up of these bones called vertebrae stacked on top of each other. But to maintain flexibility, these bones have got to move, okay? And so to have stability, you have joints. You've got joints between the bones, areas where the bones move. And by the way, they all look about the same in different parts of the spine. So your lumbar part of the spine, these bones and joints look very similar. However, when you compare to the cervical part of the spine, which is way further up, you can see there's changes that go on. The vertebrae go from being pretty big, weight-bearing structures to smaller vertebrae. The discs go from being huge discs to tiny discs. So this morning we did surgery on someone's cervical spine on their neck, and this afternoon we did lumbar spine. And the part of the spine that we're talking about that causes 85% of the problems with back pain, well, that's called the disc, that white thing right there. And discs are built to move. They're built to absorb forces, compression, and distraction. So if you pull your spine apart, they kind of hold it together. If you push down on the spine, they kind of resist the compression. And these discs have an outer wall called the annulus fibrosus. It wraps around circumferentially. So if we were to pull out one of these discs and kind of flip it so we're looking at it, you know, with the front of the disc pointing down, the back of the disc pointing up, you can see the wall, which is this yellow thing, and the jelly is red. If you get a tear in the wall, the jelly can actually push through the tear and bulge out. So this is what everyone calls a herniated disc, okay? But the truth is the jelly that's stuck in the tear is also herniated. Herniation means it's out of place. It's when there's something out of place. So if your intestine herniates down through a hole in your inguinal area, you get an intestinal herniation, an inguinal herniation. So herniations are very common in medicine. We see them throughout the body. And an intestinal herniation is something fixed by a general surgeon. But we fix herniations in the disc at Duke Spine Institute. The difference from what we do is we actually go in and repair this with a laser. Other doctors don't know how to do that, so they go in and they'll take the disc out and they'll just fuse with screws and rods because they don't know how to fix it. They've never been taught, they've never been trained. All they know how to do are fusions, which is bad for you folks because that means most of the doctors you talk to are just going to recommend what they know how to do, what pays their bills, which is fusions and artificial discs. But there's far less invasive surgery now available. We had this model made, and if you look carefully, you can actually see the annular tears in the back of the disc. Can you guys see those tears?
Yeah.
There's one there, whoops, one right there, and one right there. This is the Duke Spine model. It was made specifically for Duke Spine Institute, and we have been teaching people this stuff for years. Trying to get everybody to understand you don't need to have major invasive surgery to get out of pain. As a matter of fact, the Duke laser disc repair is your best option. So we've got questions. This lady's surgery went perfect. Couldn't have gone better. She came from Texas with her husband. They got frustrated. They weren't getting answers. She had already had like five plus surgeries on her back. You could see it all done. There was metal galore, fusions, scar tissue, bone, stimulators, generators, wires in her spine. Folks, this is what the doctors are doing to everybody today. Why? Because of this. Money. I'm going to have to bring some money in here from now on so I could show it to you guys and just do this, you know, because that's all these doctors give a shit about, to be honest with you, is making money. And that woman has literally $500,000 worth of surgery on her back from what I could see. Going in the front again, putting in the stimulator, going in the back, putting in the bone graft. $500,000 to $1 million worth of surgery already done. And all she needed was a simple procedure done for less than $50,000, never needing anything else done. Okay? That's about 98% of our patients. So she came, we fixed her disc. I hope she does well. I don't know for sure she will do well until she wakes up and she tells me how she's doing. But based on treating thousands and thousands of people just like her, I could tell you that I expect the surgery to go very well. All right, we'll take our first question.
First question comes from Darren Sanders on Facebook, and they ask, how have other neurosurgeons criticized your approach? If so, how?
Well, it's a great question. How have other neurosurgeons criticized my approach? If so, how? So, first of all, 99% of other neurosurgeons, and there's about 3,500 neurosurgeons in the United States, they've never seen my approach. They don't even know it exists. It's so advanced, they have never seen it, they've never been trained on it. That's number one. Number two, let's take a step back, because I think some people don't understand who I am. Before I was an endoscopic surgeon, I was a metal lord. Okay? What is a metal lord? What it means is about 10% of the spine surgeons, neurosurgeons in the world do about 80 to 90% of spine surgery. Okay? In other words, most spine surgery is done by a few of us. I was one of those few. And I was doing more fusions in people's necks and backs than 99% of spine surgeons worldwide on a daily basis. I had racked up over 1,000 lumbar fusions. If you don't believe me, just go to my YouTube channel and watch me do them. They're on the YouTube channel. I was doing cervical fusions. I've done over 1,000. I've done over 500 posterior cervical laminectomy and fusion. In other words, I was one of the top fusion surgeons in the world, doing not just multi-level fusions, but doing it all outpatient, meaning you go home 2 hours after surgery. No other surgeon in the world is able to do multi-level fusions, sending people home 2 hours after the surgery. Thoracic, cervical, lumbar, didn't matter. Okay? We were, and we've been doing it for 10 years. So even if doctors now, some of them are starting to do multi-level fusions, sending patients home the same day, we've been doing it for 10 years here at Duke Spine. So what I'm getting at is, I'm not some schmuck neurosurgeon who just happened to stick a tube in somebody's back or neck and just, that's my surgery that I've ever done. I've been doing everything everyone else has done. So in neurosurgery, here's bragging time. There's one neurosurgery program, and there are 150 neurosurgery programs in the United States. There is one that is the best. This is going to hurt some ears. I'm sorry if it hurts your ears. But I grew up in a time where the winner got the trophy. Everyone else, the losers, didn't. And I was a loser many times. I didn't get a trophy. But in my generation, and I'm 53, we rewarded hard work. We rewarded success, and everything was a competition. Basketball games, soccer games, school was a competition. Who's going to get the highest grade in class? So that was my generation, very different than today's generation. And today, everyone's a winner. There's no competition. We're all equally good. That shit didn't fly when I was a kid, okay? And the people that grew up with me, they know what I'm talking about. There was a competition every day, and whether it was on the playground or in school. And what happens is, through this competitive system of education, you start to get the top of every class from elementary school, high school, then college, then med school. And when you are number one in medical school, you get to go to the best neurosurgery training program. When you're number one of all the medical schools, you get to be picked up at the best neurosurgery training program, which when I was training, it was the University of Florida in Gainesville. They took 2 residents a year. They took the 2 very best medical students that had the most research done, the best publications, the best all-around doctors who were going to be the most successful neurosurgeons. That's what every residency program wants. They want the 2 best to become the best, so that makes their program more famous, more well recognized. It brings a great sense of pride. So when I was applying for neurosurgery, I was ranked number 1 in the United States. I was solicited by Harvard, Hopkins, Columbia. They all wanted me to go there. I chose the University of Florida because it was the very best neurosurgery training program. So you can consider this neurosurgeon talking to you to be in the top 10 neurosurgeons my year that I applied, okay? And I went to the best neurosurgery training program, which means for 7 years, day in and day out, I did a lot of spine surgery and a lot of brain surgery, and I did it with the very best neurosurgeons in the world at the University of Florida. So when I graduated, I could do anything in the brain, anything in the spine. Clip aneurysms, AVMs, spine surgery, fusions, take out tumors out of kids' brains, shunts, whatever was required, I was capable of doing. Over the years, my practice has evolved to spine surgery, and I've focused on spine. I've gone from being a big-time metal doctor, putting in lots of fusion and metal and artificial disc, to now I do endoscopic. So that's the person you're asking questions to. You're not asking some black sheep who was trained at some shitty program, some corner of the world. You're talking to a world-renowned neurosurgeon who was trained at the very best neurosurgery training program in the world. And there were only 2 of us my year, 2 of us every year selected. My co-surgeon was Dr. Paul Tolentino. He trained at Harvard for medical school and Harvard for undergraduate. So that he was number 1 in his class. So that just gives you an idea of who I am, okay? So when we ask questions of Dr. Deukmejian, let's be mindful of those facts. All right. What do the other neurosurgeons think about endoscopic spine surgery? Again, my answer holds true. Most of them have no idea that it even exists because they've never been exposed to it. Maybe like you, they just tuning in for the first time and finding out about it, okay? But that's maybe not their fault because their training program didn't expose them to it. They're surgeons that were their faculty, kind of like at Hogwarts with Harry Potter, right? They're going to learn the spells that their faculty teach them. They're going to learn the magic that their faculty teach them. So if your faculty doesn't do this certain kind of magic, or if your attendings don't do a certain kind of spine surgery or brain surgery, you're not going to learn it at your training program. 99.9% of neurosurgery training programs don't teach endoscopic spine surgery. They don't. It's just, and same thing with orthopedics. So it's a new form of surgery that is not widespread, that most people don't know about, which is why we're broadcasting our surgeries. We're not broadcasting surgeries because I have nothing better to do. We're broadcasting surgeries because you're not going to hear about this surgery from other neurosurgeons because they don't even know it exists. Well, was there another question to that?
There's a lot more questions.
All right, so we got a lot more questions. We'll keep going.
This next comes from Trust on YouTube, and they said, I had an MRI last week and had CD images, but I don't have the report yet. I have CDs from 3 years ago. I do not have the report back from the MRI from last week. I want to have this surgery ASAP. It takes, I did not take the cortisone shots that I was told I need. I think they are dangerous and don't think they do any good. I'm in pain every day. Thank you for taking the time to answer my questions. The questions are: it takes 12 months to heal with this surgery. No, natural healing, correct? And do you have to wear a back brace after surgery? If so, how long?
Trust, thank you for an elaborate question and still processing all the information. It amazes me how some people can type so fast. I am a very slow typer. So Trust, to answer your questions the best I can, number one, an epidural. If you do an epidural with a doctor who's good at it and they're safe, you can do an epidural and it'll probably help ease the pain for a little while, okay? And I recognize the fact you don't like epidurals, you're worried about them. I don't either. They don't fix anything, but they can make you feel better while you're waiting to get definitive treatment. Definitive treatment for a disc problem is surgery. Whether it's the Duke laser disc repair or a fusion, it needs to be something that's going to fix the problem permanently for you. Problem with fusions, to be quite honest with you, even when they're done by the very best surgeons, there's still lots of scar tissue and pain and muscle damage and narcotic painkillers and long recovery and being out of work for a long time and permanent loss of movement in your spine. So even with the best fusions, I still don't recommend the best fusions, okay? I used to do them. Now, endoscopic surgery, that's the way to go. Fast recovery, fast healing. What takes 12 months to heal is the disc, but you're not going to feel that while you're healing. So the people that I fix with the laser surgery, they come the next day, and about 90% of them, their pain is completely gone by the next day. 10% of them still have some aches and pains, either from before the surgery or after, and they need more time to heal, okay? But 90% of the time, your pain is gone when you wake up and you come back the next day. What is not done is that little hole in the back of the disc, that 3mm hole that I've cleaned up, it needs to seal. And it will seal now. And when you say naturally, it will seal naturally because I clean the tear with the laser. But if you don't clean the tear with the laser, it will never seal again. And that's what people don't understand. And the reason for that is, if you look carefully at this herniation, the torn edges of the annulus, they want to come together and seal. Your body wants to heal this, but it cannot, because the jelly from the center is stuck here between the torn edges. And the jelly is made up of a completely different substance than the wall. The wall is made out of collagen. The jelly is made out of proteoglycans, which are complex proteins with sugar attachments. And these complex proteins with sugar attachments, they don't get along with the collagen at all. As a matter of fact, they piss the collagen off. So while your disc is trying to reseal and it's bumping up against the jelly is telling the annular fibers, hey, we're not moving. So it's like somebody putting their foot in your door. You're trying to close your door. It cannot close as long as the foot's there. So what I do, I go in with the laser, I remove that jelly out of there, the nuclear stuff, and that allows the annulus to seal. It takes 9 to 12 months for the annulus to fully seal. You are correct about that. So during that time, you have to be careful not to re-injure your disc, because if you do, you're going to be back again for another surgery, and you don't want that. So if you let the disc heal by not lifting heavy things, and 40 pounds is the restriction I give everybody, 40 pounds. No lifting over 40 pounds. And you don't do any bending at the waist, you're not going to re-injure your disc. So as long as you don't bend and pick things up from the ground in the first 3 months, as long as you keep your lifting under 40 pounds your first year, your disc will heal naturally after the surgery. It will never heal naturally without the surgery. I hope I got that. And then what was the second question she asked there at the bottom?
Last question was, do you have to wear a back brace after surgery?
You do have to wear a back brace 6 weeks. That's what we recommend. The only purpose of the back brace is to prevent you from bending over. A lot of my patients are out of pain right after surgery. They go home and they're like, hey, I don't have any more pain. I'm fixed. And so they start picking things up in the yard, like, mulching or whatever they're going to do. And they re-herniate. And the reason why is because they're feeling so good, they think everything is healed up, but it's not. The fact you have no pain after surgery doesn't mean you're healed. It just means that there's no pain. What healing has to happen is the disc, and that thing is painfully slow. Next question.
Next question comes from, these next two questions come from Oz on YouTube, and he asked, when is that scheduled fusion you have soon?
All right, Oz, I'm sorry. We got to figure out when the scheduled fusion is. I'm going to call Richard right now. Give me a second while I'm answering your second question. But Oz, you keep asking about the scheduled fusion. I appreciate that. I'm glad you're looking forward to it. I'm not, because fusions are hard work, and it's a 4-level fusion. So I'm going to be there for 4 hours. It will be outpatient, and the patient actually will go home about 2 to 3 hours after the fusion. That's how good we do fusions at Duke Spine. You go home with a 4-level fusion. He's not answering his phone. Let me text him. He may be on the phone with somebody. So the 4-level fusion we're doing, when we say 4 levels, that means I'm cleaning out 1, 2, 3, 4 discs. I'm literally going to scrape all 4 discs out, and I'm going to put 4 cages in, and I'm going to put 10 screws, 2 rods, 2 cross links, and then bone graft on the side. I'm going to do all of that by also performing osteotomies. If you'd like to read a paper I wrote on fusions on the lower back, you just go to PubMed and type in Duke-Majan. You'll see a lot of fusion patients. Some of them are my brother, who's also a neurosurgeon, Armin Duke-Majan, but look for Ara Duke-Majan. You can see one of my papers is, all right, he's talking to a patient. When is lumbar fusion happening? So I'm asking one of my schedulers, when is the lumbar fusion happening? Hopefully we'll have an answer soon. Point I'm trying to make about the fusion is that it's a long, painful surgery for me and the patient. All right, who's next? Can you bring me some water, please? It'll make my mouth less dry, and it'll make the words come out easier and faster.
Right, so you need water because we're planning on doing like another hour-long sermon.
Yeah, but if I have water, it'll be much shorter. I'm talking to one of my research assistants. All right, what's the next question?
Next question comes from Oz once more, and they ask, do you ever work on a personal injury lien for personal injury cases?
Do we ever work on personal injury liens for personal injury cases? The answer is absolutely yes. We will, but we will not do we will not do the whole surgery on a lien, and the reason is we have real costs. We can't gamble that the patient, are going to get money with your insurance company, right? So we will gamble a little bit, but we need some money to cover our overhead in the meantime. So basically, let's say the surgery is 100 grand. I'm just going to pick a number, 100 grand. We would ask for a percentage of that money up front from the patient. And the way you should do that, if you ask me, if you don't have the money, is you borrow it. There are companies out there that will loan money to you if you have a car accident case. They'll loan you money, and you can take that loaned money and pay your deposit, which we need to receive before your surgery.
Next question comes from Casa, once more on YouTube.
Hello, Casa. Welcome to our live stream at Duke Spine.
They ask, how is the disc preserved with your procedure after you enter it and then remove your tools?
That's a great question, Casa. Thank you for asking. So when I enter the disc, if this is the herniation, this is the damaged part of the disc right here. All the rest of the disc is fine. We don't enter the disc in somewhere where it's not fine. We enter the disc in the damaged area. So I actually go through the herniation, through the tear, and I get to the base of the tear and I use a laser to remove it all. So we're not actually damaging the disc at all. We're going through the damaged part of the disc. Think about the Ukraine right now. Ukraine has many cities that have been destroyed by the Russian army, or whatever they call it. Our army is entering the Ukraine to help the Ukrainians by going through a already damaged city. We're not going to go through a normal city and destroy that with our tanks and machines. We're going to go through an already damaged city to get to the fighting that's happening deeper in the country. I hope that analogy makes sense, but the part of the disc we're passing through is already destroyed.
Next question comes from Darren, once more on Facebook, and they ask, why aren't they teaching this technique in medical school? I have a major fusion and I'm still in pain.
Yeah.
Sorry.
So Darren, the reason they're not teaching it in residency in medical school is simple. It's economics. It's money. Okay? You see these screws and rods? Every time a patient has a fusion, it's $100,000 changing hands. Okay? Who's making that money? The surgeon, the hospital, and the company that makes the screws and rods. Those three people, we call them stakeholders. They're making all the money. The implant company, some examples are, you may have read about these companies, you should look them up. Medtronic, spelled M-E-D-T-R-O-N-I-C. Medtronic. That was the company that was in the news when Obama was president. They were trying to move their headquarters out of the United States over to Ireland where they don't have to pay taxes. I think they make like literally $50 billion a year. and they were trying not to pay taxes so they didn't have to help cover whatever our government decides to spend money on. I pay taxes, and they were not paying taxes, and they make a heck of a lot more money than we do. Anyway, that company makes billions of dollars on those screws. This screw right here you're looking at, we pay $1,000 to them per screw. Now, it probably cost them 25 bucks to make each one, but we pay 1,000. Okay, and when I say them, I don't mean Medtronic, because I don't buy my screws from Medtronic. I buy them from another company. But the point is, there's a lot of money in the hardware. There's a lot of money for the surgeon. There's a lot of money for the hospital. Why are they going to go from making $100,000 for back surgery to making, $30,000 for a back surgery? Okay, it's the economics. They don't want to lose that revenue. I can't change that. I'm trying, but I cannot. It's too big of a job for one person to do. We need more people like you angry that you're a victim of financial gain and corruption, essentially. And we need more people doing something about it. I am doing what I can, and I'm spending my own money doing it, by the way. This broadcast, everything we do here at Duke Spine educationally, nobody gives us money to do it. There's no foundation. There's no Bill Gates showing up with a suitcase. Hey, Dr. Duke, great job educating people, doing what's best for the American public. Hey, here's some money, keep going. Nobody has ever done that to us. We need the money. We've asked for it. People never gave, so I gave up asking. I don't even bother anymore. We just do these broadcasts for free for you, but I pay for them out of my own pocket. Okay? Why? Because, hey, I believe we're here for a purpose, and my purpose is to change the spine world. Okay? I'm not going to change politics. I'm not going to change other political issues. I'm going to fix the spine world, and that's what I want to do. Spines and coral reefs. Next question.
Next question.
Their comment. It's already
Yes,
public.
no problem. This question comes from Sago on YouTube, and they ask, "Hey, Dr. Duke, I'm one of your patients. However, I am still saving up for the surgery. I was diagnosed with disc bulges, and I literally feel my left shoulder being gradually displaced downward, and my spine shifting. What is the best way for me to maintain my spinal neutrality until I get the surgery?"
So, great question. This is a person who, I can't discuss details, of course, but just in general, they're feeling that situation we talked about during the surgery. You see how nice and straight the spine is? You get damage to a disc, and what happens is the spine starts to kind of, I'll use the word deflate, even though it's probably not the right word. But it starts to deflate at that disc on the side that's damaged, and the facet, and so you start to get a shifting of the spine to one side. Well,
I'm so sorry. They just added that it was the C spine, C4-5, C6, C5-6.
No problem. So their discs are damaged. It's called, the bones are settling down, but instead of straight, they're settling slightly kinked to the side and twisting. That can shift your spine and cause scoliosis. That is the most common cause of scoliosis or twisted spine. So what can you do? There's not much you can do, to be honest. You could try some chiropractic adjustments, maybe with some stretching of your spine, but honestly, I don't know that that's going to work. I wouldn't recommend it normally, but if you want to try it, you can. You can try a teeter table where you strap your feet in and you hang backwards, upside down. Just be careful, you can hurt yourself with that thing if you're not careful, but basically you need something done surgically.
And that is it for questions.
Wonderful. Well, thank you. I hope you all enjoyed our conversation, and I hope you know a little bit more about Dr. Duke Majan and some of my background. The new website, when it does eventually get launched, it's going to have a whole bio section on my achievements and who I am. so that hopefully you guys will have a better idea of the training that I've gone through and the experience that I have. And it's not limited to endoscopic surgery. Okay, have a great day. We'll see you all Thursday.